Okay, so welcome all of you, those who are here for today's session. So I hope the last session must have been a little fruitful because we did discuss a lot of important topics and we are going to discuss another set of important topics today in terms of MCQ. So I expect that all of those who are listening to the class, please start answering in the chat box whenever the question is asked. Even if you don't know the exact answer, you can keep guessing and revising whatever has been learned till date. So we'll begin with today's session. So the first important topic that we're going to discuss is acute laryngotracheobronchitis. Now, this is a very, very small topic, but still very important because there are classical clinical features and classical signs and symptoms which are seen in this disorder. Can anyone tell me the other very common name used for this particular disease? What is the most common term that is used? Yes, it is croup. Very good, Narayan. Fatima, yes, that is croup. Okay, so let us see the important things related to this particular disorder. Okay, so first question is, what are the viral agents that can cause croup? All except, please read the question always very carefully, which is not the agent that can result into croup. Please type in your answers in the chat box. So out of these, which virus is not going to cause croup? Okay, Fatima has answered option number C, that is hepatitis B. All right. Yes, that is very commonly asked question in the exam. They usually ask you the most common organism, or they can also ask you which are the organisms except. So that is absolutely right. Yes, Shiva has also answered it right. So hepatitis B is very commonly understood that it has got nothing to do with respiratory infections. So even if you don't know the answer, you can easily use your common sense again to answer this particular question. So croup basically is always caused due to respiratory viruses. So all those viruses which are responsible for any kind of respiratory illness can result into the onset of croup. So parainfluenza virus type 1, 2, and 3. This is the most common organism responsible for causing croup. So parainfluenza and influenza, these two viruses are very, very influential in this particular disease. Adenovirus is also a virus that results into respiratory tract infection and therefore it can cause croup. Respiratory syncytial virus or RSV is one of the most common virus related to childhood respiratory illness. So RSV is also well known to cause croup. And measles. You all should know that measles is not only a disorder of skin and fever involvement, it also results into post-measles respiratory complication in terms of pneumonia. Sometimes this infection can also cause wheezing that will result into onset of croup. So definitely hepatitis B virus has got nothing to do with respiratory illness. So that is the right answer. All right. So next question. Bacterial agents that cause croup include. So which bacterial agents can result into onset of croup? Put down your answers in the chat box. Fatima, Shiva, Narayan. Okay. All right. Yes, not A. Very good. Okay, so Coxiella has nothing to do with respiratory illness again. Apart from that, all the atypical viruses, atypical bacterial agents and also the typical bacteria which are known to cause pneumonia in children, they can again result into inflammation of the airway causing croup. So Mycoplasma pneumoniae, Corynebacteria diphtheria, Staphylococcus aureus, Streptococcus pneumoniae, H. influenzae, and Moraxilla. All of these are well-known organisms that result into respiratory infections. So they can definitely cause inflammation of the airway, and that is how it can result into laryngotracheobronchitis, that is known as croup. So these agents are very, very important to be known. Out of these, for viruses, you must always know that parainfluenza is most common. And apart from that, certain bacterial agents can also cause croup. So next question, clinical features of croup include. So how will a child present clinically if the child develops croup? What all can happen in a respiratory infection? Even if you don't know all the symptoms, you can easily go through each and one symptom and then decide whether this could be present in a respiratory illness or not. Please put down your answers. Okay, all others except abdominal distension. Yes, abdominal distension cannot happen in this particular condition because we are talking about respiratory symptoms. So what is rhinorrhea? Rhinorrhea is some kind of nasal discharge and congestive illness kind of features which happen almost in all viral respiratory illness. Low grade fever, obviously it starts with a low grade fever. So if it is a viral infection, it will have a low grade fever. Barking cough is a characteristic feature that is seen in croup. So whenever you are in a pediatric emergency, you see a toddler or you see a preschool child who's coming to you and has got a dog-like voice or is having a cough which represents a barking type of cough. So it is a classical presentation of croup. Stridor definitely can happen in this. Why? Because it is an inflammation. So whenever there is inflammation of the airway, what will happen? The airway will get narrowed. So if it is narrowed down, it will result into obstruction of the flow of the air. So that is why stridor will happen. Even in last session, we had discussed about the stridor. So we have seen all the important causes related to stridor. Hoarseness again because the vocal cords are inflamed. So that is why there's change in the voice. Difficult breathing. Definitely because the airway is getting inflamed, the amount of area that was available for the air to pass through, that is getting obstructed. So when the child lies down at night, so what will happen? In that supine position, the obstruction is all the more. So because of that, there's difficulty in breathing and the child will have a very disturbed sleep at night. Chest wall indrawing, again, it will happen because of increased respiratory rate or respiratory distress. So these are all commonly seen symptoms that is present in croup. Okay, next question. All are diagnostic tools for croup except. So what is not useful for diagnosis? All except. Very tricky question indeed. So all are diagnostic tools except. Okay, any more responses? Shiva has answered. Nayana has answered. Any more responses? Okay, so now for diagnosis of croup, basically, it's very, very important that initially we suspect it is the onset of croup. So if we do a frontal X-ray of the neck, okay, if we do the X-ray of the neck, what sign do we get on the X-ray? Can anybody mention in chat box? Why do we do an X-ray if it's a diagnostic tool? Any response? Okay, so what is happening in croup? Basically, there is inflammation. Yes, there is narrowing of the airway. Very good. So what will happen? So if this is the airway on the X-ray that we see, this is the trachea. It is getting divided like this, right? And this is the lung fields that we have. So basically in croup, what is happening? There is inflammation, right? So whenever there is inflammation, what will happen? There is going to be narrowing of the airway. So we are going to see this kind of a beaking. So when this beaking is present, so this narrowing of the airway, this is known as steeple sign. So this is a steeple sign. Why is it called a steeple sign? So in a steeple sign, basically, whenever we visit a temple, we are going to see there's a narrowing towards the end. So there's a broadening initially, and then there is a narrowing. So this type of sign is known as a steeple sign. So that is a very classical sign that we see in croup. Apart from that, can we take a nasopharyngeal aspirate? So whenever we do the culture of the aspirate, if there is any organism, specific organisms that we have learned about, so that can grow. So nasopharyngeal aspirate can again be a very useful diagnostic tool. WBC count, yes, it is very helpful if it is a bacterial infection. So in bacterial infection, what will happen? The WBC count will rise. So it is going to show you a definite evidence of infection. RT-PCR, why not RT-PCR? Because most commonly it is caused due to a virus, right? So most of the time, maybe the virus cannot be isolated. So it might not result into the diagnostic evaluation. So that is the right answer. Okay, next question. Management of croup includes which of the following? How do we manage a case of croup? So if suddenly a child comes with a barking cough-like experience and is having respiratory distress, what all measures would you take in such a case? Put down your answers in the chat box. If you have understood the entire topic of croup, it is very easy to answer. The management would include all of the following. What are the important steps in the management? Yes, very good, Diana. Antibiotics has got no role in management of croup. Now, why is it that so? Now, it is because in croup, we have seen most common causes para-influenza virus. So do we give antibiotics in the treatment of viral infection? Not at all. So viral infection cannot be treated by antibiotic dose. However, bacterial infections are also causative organisms of croup, but not very, very commonly. So that is why initially we have to give supportive care. That means we have to make the child comfortable. We have to put oxygen support, make a good position for the child. IV fluid to rehydrate the patient. Oxygen inhalation, because definitely it's a respiratory infection, there is going to be fall in SpO2 level. The most important step in the management of croup is giving a steroid dose. So the drug of choice is dexamethasone. So we give a start dose of dexa so that the inflammation subsides. Inhalation of epinephrine is another very, very important step in the management. So this is going to result into dilatation of the airways. So the relief of the symptoms can happen if there is dilatation of the airways, which were initially narrowed down. Antibiotics, definitely a big no. So this is how we actually manage a case of croup. So that is about the management. Are we clear about this topic? Please put a thumbs up, all of those who understood about croup. Any doubts anybody has, please keep asking. All right, so let's move on to the next topic. So randomly important topics which have been taken up for pediatrics. So another very, very important topic is neonatal sepsis. So from pediatrics, we jump to neonatology. That is how the MCQs are framed in the exam. So you have to always keep your minds open. You have to keep thinking about the important answer. And the best part in the MCQ is that the answer is right in front of you. Even if you have read it once, you can easily answer. Okay. So neonatal sepsis. Now, what is neonatal sepsis? First and most important question. What is a neonatal sepsis? Please take time, read the options carefully and put down the right answer. Okay, so Nayana has answered that B is incorrect. All right. So let us read each and every option carefully. Clinical syndrome characterized by signs and symptoms of infection without accompanying bacteria in the first month. So that is absolutely right. In the first month of the baby, that is till the baby becomes at least 28 days old, any kind of infection onset which only presents with signs and symptoms of infection without exact isolation of the accompanying bacteria in the first month, we treat it as neonatal sepsis. Now, all of you must be having the doubt that although we know that most common organisms are certain organisms like Staphylococcus, Klebsiella, why do we say without accompanying bacteria in the first month? So that is because the sepsis can happen in terms of any kind of malhandling of the baby. So we definitely treat it like a syndrome rather than treating it like a disease. So any kind of clinical features related to sepsis, if seen in a newborn, we will start to treat as a neonatal sepsis. We don't want the sepsis to spread in the body. So we always take hold of the syndrome presentation in clinical sepsis rather than isolating the organism and then treating the infection like we do for older children. So it is a clinical syndrome characterized by signs and symptoms of infection without accompanying bacteria in the first month. Does it include septicemia, pneumonia, meningitis, arthritis, osteomyelitis, superficial infections like oral thrush and conjunctivitis? No, that is not exactly the right statement. Neonatal sepsis is again an overall pulmonary sepsis that is present inside the body of the newborn. It can present with diffuse septicemia. It can present with any kind of clinical features, but superficial infections like oral thrush and conjunctivitis is not included in neonatal sepsis. So that is wrong. Let's see option number C. The most common organisms are Streptococcus pneumoniae, Klebsiella, Staphylococcus aureus, and Pseudomonas. Yes, in our setup, in our country, the most common organisms are Streptococcus pneumoniae, followed by Klebsiella and also Staphylococcus aureus. And the fourth option is it is classified as early onset and late onset. That is absolutely right. Early onset are those infections which are inherited by the baby, or basically they get those infections from the maternal genital tract. So organisms like Streptococcus pneumoniae, all of these can cause early onset sepsis. It lasts for at least 7 days of life. And after that, whatever sepsis happens in the baby, that basically happens due to malhandling of the newborn. Maybe the relatives and whosoever is handling the baby, there could be certain amount of infections which can be transferred. So they result into late onset neonatal sepsis. So these are the important statements that all of you should know about neonatal sepsis. All right, can we move to the next question? So the next question mentions, what are the risk factors of early onset sepsis? So how can a baby get early onset sepsis? So I just mentioned that early onset basically means EONS. That happens due to problems related in the mother. So even if you don't know all the causes, you can use your common sense again and mark the right answer. What could be the risk factors for EONS? Please put down your answers. All right, so Naina has answered not H and I. Anyone else who would like to put down the answer? Not H, all right. Okay, so very simple to remember, you don't have to mug it up. So EONS is basically those things which are already present as an infection source before the baby is born. So those things related to mother. And LONS is all those causes which happen after birth due to malhandling of the baby. So if we see bottle feeding and poor cord care, so these things basically happen after the delivery. So if somebody has not used sterile instruments for cutting the cord, or cord care has not been taken, maybe they are applying some kind of talcum powder or they are applying some kind of honey. There are various rituals in our country. So if the cord is not taken care properly, it might result into omphulitis or inflammation around that area. So that is basically late onset neonatal sepsis. Bottle feeding again, if the baby starts to get feeds from the bottle, it can result into a lot of infections because the cleaning part of the bottle and the nipple in the bottle, it can be a source of microorganisms if the cleaning is not done properly. So these are basically related to how you handle a newborn after the delivery. However, the other important causes which can result into early onset sepsis. Now, if the birth weight of the baby is less than 2.5 kg, itself is a risk factor. So LBW babies are always at risk of developing a neonatal sepsis. Even if the handling is proper, they might develop neonatal sepsis even with minute problems. Prematurity. So premature baby is very much prone to develop neonatal sepsis. So early delivery and low birth weight. Two of these are very, very important risk factors. If the mother had any febrile illness within 2 weeks prior to delivery, so if the mother was already carrying certain infections, it can get transmitted to the baby. Foul smelling liquor, again, very, very important. So foul smelling liquor is again indicative of what? It is indicative of basically the infection that is present inside the mother. Rupture of membrane for more than 24 hours. So if the mother complains of leaking PV for more than 24 hours, it can again result into transmission of infection inside the sterile water bag where the baby is there. So rupture of membrane again is a very important indication of early onset sepsis. Single unclean, very important words. Please remember these things. Even one unsterile examination of the personal parts or the private parts of the mother by any doctor can result into onset of infection. or even more than 3 sterile vaginal examinations during labor. So repeated examination of the vaginal part of the mother can result into introduction of infection inside the sterile bag where the baby is present. So that can also cause early onset neonatal sepsis. If the mother has been into prolonged labor for more than 24 hours, it can again result into onset of sepsis. And if the baby is born with perinatal asphyxia, that means the baby delivery time or the time of birth, that was very much prolonged. So if asphyxia is happening, again, the baby can get depressed. It can result into onset of neonatal sepsis. The base deficit values of the baby, the acidosis, all of these things, basically the acid-base balance in the body that can get disturbed. And even perinatal asphyxia results into a lot of handling of the baby with instruments, a lot of procedures which is happening to save the baby. So that can result into onset of sepsis. So these are all important causes which can result into early onset of neonatal sepsis. So it's difficult to mug up each and every point and remember it by heart till your exam. So always try to use certain tricks to remember such long topics. So early onset neonatal sepsis, all the causes related to mother. Late onset neonatal sepsis, all the causes related to malhandling of the baby after the delivery of the baby. Is it clear to all of you? Please put a thumbs up, those who understood this topic. Can we move ahead? All right. Okay, next question number 3. Clinical features of neonatal sepsis include. So what are the important clinical features of neonatal sepsis? So important clinical features of neonatal sepsis. Okay, if the baby develops 6, all of them are correct, all right. Any of the features which is not correct related to sepsis. So sepsis basically means the baby has become lethargic. I also had a lot of difficulty in memorizing so many clinical features of sepsis because until unless you don't see these things practically in your medical field, you don't, actually have that reflex of answering and remembering things all the time. So I just remembered it by a simple mnemonic. It is basically lethargic baby who is not responding to any stimulus. So first clinical feature is lethargy. Poor cry, refusal to suck. An active baby will always be crying actively, will always have a good sucking response. So if the baby is very lethargic, not responding to stimulus, that means the baby could have sepsis. Hypothermia. So active baby will always maintain a normal temperature, whereas a septic child is always going to have a low temperature or hypothermia. Hypo or hyperglycemia. So disturbance in the normal metabolism of the body. If the blood sugar level is low or if it is high, both of them are indicative of neonatal sepsis. If the baby is lethargic, the tone of the body is also going to decrease. So active baby will have a normal tone, but a baby who is very lethargic and is having sepsis will have hypotonia or decreased tone of the body. Hyperreflexia. So this is not actually right. There could be hyporeflexia. All right. So hyporeflexia is definitely a classical feature which is seen in neonatal sepsis, not hyperreflexia. Prolonged CRT. So capillary refill time. So capillary refill time will be prolonged because sepsis can result into onset of shock as well. So that will result into prolonged capillary fill time. Respiratory distress or apneal gasping. Definitely, if there is sepsis or infection in the baby, there can be onset of pneumonia resulting into respiratory distress. Alkalosis is not right. What happens instead of this? There is going to be acidosis. So whenever there is neonatal sepsis, the baby will have acidosis, not alkalosis. Brady and tachycardia both are indicative of neonatal sepsis. So decrease in the heart rate and too much increase in the heart rate. Both are indicative of certain complications of sepsis. So it is a classical feature that is seen in neonatal sepsis. So just remember a lethargic baby who is not very active, not responding to anything. So any symptom related to this particular trick can help you to correlate the symptoms of neonatal sepsis. Is it clear to all of you? Can we move ahead? All right, next question number 4. Investigations in neonatal sepsis include, so what are the investigations in neonatal sepsis? What all tests would you like to run so that you can diagnose a neonatal sepsis? Okay, let's see one by one. Western blot is not there. Yes, that is right. Rest all of them, is it right? Nayana? Let us see one by one. So blood and urine culture, obviously, because yes, all of them are right except Western blot. So blood and urine culture will definitely help you to investigate sepsis because you can grow the organism on culture. TLC count cutoff is less than 5,000 per cubic millimeter. ANC, definitely we have to use the chart to see the absolute neutrophil count. So TLC counts and neutrophil counts are very, very important for evaluation of neonatal sepsis. And as for the gestation age, we can correlate it with the chart. IT ratio equal to or more than 0.2. So IT ratio is very, very important. So toxic granules presentations, these are all important kind of screening that is used for neonatal sepsis. Micro ESR cutoff is 15 mm in the first hour. So micro ESR value is again a very important technique for diagnosing neonatal sepsis. CRP value, the cutoff is more than equal to 1 milligrams per deciliter. CRP is high. Again, it is indicative of neonatal sepsis. Lumbar puncture. So lumbar puncture is very, very important in a newborn because any kind of sepsis in a newborn can result into meningitis onset because the blood-brain barrier of a newborn baby is not very, very strong. So the infection in the blood can easily go and cross the blood-brain barrier and result into onset of meningitis. So we cannot actually find the classical presentation of meningitis in a newborn like raised ICP, seizure attacks, or increased tone of the body, unequal pupils. So because of this, we can easily undiagnose or misdiagnose the onset of meningitis. So by default, we generally do lumbar puncture of any case of neonatal sepsis to rule out meningitis. Chest X-ray, again, very important because if there is any onset of pneumonia because of sepsis, we can easily diagnose on X-ray. Western blot definitely has nothing to do with neonatal sepsis. So all of them are right except the last option. Okay, next question. Question number 5. Management of neonatal sepsis includes which of the following? So how do we manage a case of neonatal sepsis? Now, if we have understood the clinical presentations and the clinical features of neonatal sepsis, then we can definitely know what all things are required for the management of sepsis. Biopsy is not indicated. Yes, that is right, Naina. So biopsy is not required. Let's see other things. Thermoneutral environment, very important. Why? Because hypothermia is a classical feature of sepsis. So we need to give a good environment temperature. Oxygen saturation is again important because there could be pneumonia resulting into fall in oxygenation level. Warm IV fluids. Again, IV fluids can result into alteration of the temperature of the body. So we need to give warm fluids. Hypoglycemia, we need to monitor because if the sugar level fall too much, it can result into onset of hypoglycemic seizures. Volume expansion by crystalloids and colloids. So we need to see whether the intravascular volume is adequate or not. If the child is going into a stage of shock, we need to give volume expansion. Packed red cells and FFP transfusion definitely because it can result into complications of shock. It can result into anemia. It can result into DIC. So to prevent all of these, we need to support with blood products. Antibiotics is the mainstay of treating neonatal sepsis because with antibiotic therapy, definitely you can treat the infection. Bone marrow biopsy does not have any role in the management of neonatal sepsis. So are we clear with this topic? Any doubts anybody has, please ask. Please put a thumbs up those who understood this topic. Okay. So next important discussion is about respiratory distress in newborns. Okay, first question. What are the common causes of respiratory distress in a newborn? Whenever a child has got increased respiratory rate, what could be the causes of such a presentation? Okay, let us see one by one. So what is respiratory distress syndrome? Even if you don't know the answer, you can correlate that we are talking about respiratory distress. So respiratory distress syndrome can definitely be a cause of respiratory distress. So this is basically hyaline membrane disease that happens in a premature baby where the lungs are not properly formed, the surfactant is not adequate, so they develop respiratory distress syndrome. Again, very common sense. Respiratory distress. So if there is any obstruction in the airway, definitely it will cause distress in the baby. If there is any kind of aspiration, it will again increase the respiratory rate. Congenital diaphragmatic hernia. So what happens? The parts of the abdomen, they basically go and compress the lungs. So there's a defect in the diaphragm through which the abdominal loops can herniate upwards, compressing the lungs, therefore causing respiratory distress. Meconium aspiration syndrome. If aspiration is right answer, then definitely meconium aspiration syndrome would also be a cause of RD, because if the baby aspirates meconium, it can result into onset of respiratory distress because of chemical pneumonitis. Hirschsprung disease is not even a disorder of respiratory system, it's a disorder of GI system. So that is not the answer. Is it clear to all of you? Okay. Next question. Clinical features of meconium aspiration syndrome are. So what could be the clinical features of meconium aspiration syndrome? If the baby aspirates accidentally the meconium, what all could happen to the baby? Okay, so let us see. Respiratory distress, obviously, if there is aspiration, it can result into respiratory distress. There is increased risk of perinatal and neonatal mortality. Now, if the lungs are going to get damaged, there is going to be respiratory distress, there is going to be pneumonitis. It will obviously cause increased risk of mortality because the lungs can get damaged because of meconium. Proximal muscle weakness, again common sense. If we are talking about respiratory system, why will it result into proximal muscular weakness? It is something to do with neurological disorders. Severe acidemia. So we all know whenever there is respiratory distress, we do an ABG test in which we look for acidosis because the oxygenation is not proper in the body. So severe acidemia can happen because of meconium aspiration syndrome. Adverse neurological outcome. Is this possible in this case? Can a baby of meconium aspiration syndrome have adverse neurological outcome? No. Yes, they can have. Why? Because if there is aspiration, it can result into permanent damage inside the lungs. That is chemical pneumonitis. So once chemical pneumonitis happens, what will happen? There is decreased oxygenation level. If there is hypoxic attack in the baby, it can result into damage in the central nervous system as well. So adverse neurologic outcome could be a complication of meconium aspiration syndrome. And long term, they can have episodes of pulmonary hypertension. So these are all basically chemical changes that happen inside the lung if the meconium is not aspirated out in time or the child is not ventilated properly in time. So these are the complications that can happen. All right. Okay, next question. Treatment of meconium aspiration syndrome includes all except. Now, if you have understood what is MAS, then you should understand what all steps we require for the treatment. So answer for question number 3. So let us see, do we need to correct the blood glucose level and calcium levels? Obviously, yes, because we don't want any further acidosis to happen in the body and worsen the clinical picture of the baby. Circulatory support with normal saline. Yes, we have to always give supportive treatment in any kind of respiratory distress in the patient. Be it meconium aspiration syndrome, be it congenital diaphragmatic hernia, we always need to look for ABC, that is airway, breathing, and circulation. That is the golden rule for the treatment of any case in any field, be it pediatrics or medicine. So we always have to give circulatory support with normal saline. We have to give a good neutral environment by maintaining the blood glucose level, the calcium level, and to avoid the onset of acidosis. Airway suctioning and oral suctioning, very, very important. Why? Because whatever particles are still stuck inside the airway, they will get excreted out. So that will not get further aspirated by the baby and cause further damage in the lung. Oxygen and ventilatory support is the most important part of treatment for meconium aspiration syndrome. We have to Okay, so antibiotic treatment is again can be done because it can result into infection and we have to control the further spread of the infection inside the newborn. And last is corticosteroids are contraindicated. So is this option right or wrong? What is the treatment of choice for chemical pneumonitis part that happens inside meconium aspiration syndrome? Should we give corticosteroids or should we not give steroids? Yes, very good. We should give steroids. So steroid giving is one of the mainstay of the treatment. So it is not contraindicated. It is in fact suggested to give corticosteroids so that we can decrease the inflammation that has happened in the airway. Okay, so next important question from respiratory distress. Another very common thing that happens because of respiratory distress or that results into respiratory distress is TTNB, transient tachypnea of the newborn. So what are the features of transient tachypnea of newborn except? Which of the following is not a feature of TTNB? So let us see the options. Tachypnea, retractions, and cyanosis can be present. So as the name suggests, TTNB, it is transient episode of tachypnea which happens in a newborn. So definitely tachypnea retraction, and because of certain extent of tachypnea, for some time cyanosis could be present, it might not be present. So that is absolutely right. Decreased oxygen saturation, yes, it can happen because of the problems of fluid accumulation inside the lungs that happens in TTNB. It happens because of delayed clearance of fetal lung fields. So that is the main cause that is present in TTNB. If these are the lung fields of the newborn, this is the airway. So basically at the fissure level, there is accumulation of fluid in the interlobar fissure. Now, because of this fluid, there is going to be improper oxygenation in the body, which can reflect in terms of desaturation. And because of delay in the clearance of the fetal lung field, it can result into onset of tachypnea. It is usually benign and self-limited process is absolutely right. We don't need to give very aggressive treatment for TTNB. It is a self-limited process. By around 4 to 5 hours post-delivery, the TTNB episode is going to resolve. The fluid inside the lungs will get cleared out, and after that, the baby is going to have a normal respiratory rate and will always have resolution of features like tachypnea, retractions, and cyanosis. Generally affects infants born at preterm gestation. That is absolutely wrong. TTNB is a feature which is classically seen in term babies or a post-term baby. It is not seen in a preterm baby. In a preterm baby, what happens is hyaline membrane disease. So these two things are very important to know. A preterm baby will always develop a hyaline membrane disease, and a term or a post-term baby will always develop transient tachypnea of newborn. Okay. Is it clear to all of you? All right, let's move to next question. So chest X-ray of TTNB shows. What could you find in the chest X-ray of a transient tachypnea of newborn? As I mentioned, what happens in TTNB? So you can imagine all the important things that can happen. So how will it present on a chest X-ray? If there is fluid inside the lungs of the baby, then what all could be present on a chest X-ray? Okay, let us see one by one. There is prominent perihilar streaking known as a sunburst pattern. This is the classical feature that is seen inside the X-ray of a TTNB. Okay, so perihilar streaking is again because of fluid accumulation. So sunburst pattern is seen in TTNB. Coarse fluffy density. So coarse fluffy densities again could be seen. Why? Because it is going to result into inflammation of the smaller airways inside the lung. So it can present with coarse fluffy density. Hyperaeration. So when we see the size of the lungs on the chest X-ray, it might look hyperaerated. The total volume of the lungs, which is normally seen in a newborn, it might look a little bigger than that. So that again happens because of fluid accumulation. which is going to look normal otherwise when the fluid gets absorbed back. Normal cardiac shadow. Will you find a normal cardiac shadow, or is it going to be increased or decreased in a newborn? Anyone who would like to answer about option number D? So cardiac shadow might show apparent cardiomegaly. Okay, it can show apparent cardiomegaly. Okay, so normal cardiac shadow is not the right option. Widened intercostal spaces. So widened intercostal spaces again because of accumulation of fluid. And fluid-filled interlobar fissure, that is the classical sign which is seen on the chest X-ray. So whenever we see the interlobar fissures, we see that it is always going to be more in area as compared to normal chest X-ray, which is because of accumulation of fluid. Okay, do we find pleural effusion and pneumothorax? Not at all. Pleural effusion, pneumothorax are classical clinical conditions which are seen apart from the normal presentation in a newborn. So if there are certain other complications, then only we can have pleural effusion and pneumothorax, not in a case of TTNV. So in chest X-ray, these are the important findings that we see in a case of TTNV. Okay, let's move on to next topic, shock. Very simple and very, very important topic, neonatal shock, or it could be present even in children. So what are the types of shock which we see clinically? There are important types of shock. There are 5 types of shock. So what are the 5 types of shock that we see? Any answers? Okay, A, yes. Hypovolemic shock is one of the most common type of shocks. Apart from that, do we have a cardiogenic shock in children? So cardiogenic shock can also happen. Whenever there is a very fulminant cardiac disease, it can result into abnormal pumping out of the blood to the whole body, causing a cardiogenic shock. Obstructive shock. Have you heard of obstructive shock? Is there any term known as obstructive shock? Yes, so obstructive shock can also happen because there is some kind of obstruction to the blood flow. So all the body part will not get perfused properly, like a coarctation of aorta. So that will result into obstructive shock. Distributive shock. Yes, there is something known as distributive shock again, because again, the blood volume is not getting equally distributed in the body. There can be overall decreased perfusion inside the body. And septic shock is also one of the most common types of shock that we see in newborns. So there's nothing known as a vagal shock. So the 5 important type of shock that we have is hypovolemic, cardiogenic, obstructive, distributive, and septic shock. Okay, next question. Hypovolemic shock is, so what defines the hypovolemic shock? What is a hypovolemic shock? Anybody would like to put down the answer? So basically, what the name suggests, that is the meaning of the shock. Hypovolemic, that means the volume is decreased. Okay. So characterized by fluid loss, obviously, if there is body is having fluid loss because of maybe GI losses or any kind of loss, it will result into hypovolemia. Decreased preload in the body. If the blood volume is already low, or the fluid overload is not, the fluid is not an adequate amount inside the body, there is loss from the body, it can decrease the preload on the heart, because of which the pumping out of the blood from the heart is going to get affected. Water, electrolyte, plasma, or blood loss. So anything in the body could be lost. It could be either blood loss, it could be loss of water, it could be loss of plasma, it could be electrolyte disturbances. So these are the important things that happen in a hypovolemic shock. Does it happen due to congenital heart disease, myocarditis, cardiomyopathies, or arrhythmias? No. These can result into cardiogenic shock, not in hypovolemic shock. Post-spinal cord or brainstem injury, again, these will not result into hypovolemia. They can result into neurogenic shock. So it is very important to know the meaning of each type of shock. As the name suggests, hypovolemic, that means hypovolemia or decrease in the volume. Okay, next question, causes of obstructive shock are. So what could be the important causes of obstructive shock? So what things can happen inside the body of the baby that can result into obstruction of the blood flow? So anything which has immediately happened that is not allowing the blood to get equally distributed can cause obstructive shock. What could be the answer here? All right, let us see one by one. So tension pneumothorax, whenever there is tension pneumothorax, it can result into obstruction towards the perfusion. And also it is going to deeply affect the lungs, which will not cause proper ventilation inside the body. Pericardial tamponade. So if there is pericardial tamponade, again, it is going to result into obstruction. So improper perfusion of the body. Pulmonary embolism, same thing. It is also going to affect the proper ventilation inside the body. It will not allow proper oxygenation to happen. So it can cause blocking of the vessels, resulting into obstructive shock. Anterior mediastinal masses, can it result into complete obstruction? So if there is a mass, it can result into problem in distribution of the blood, but it will not cause complete obstruction. So that is not a right answer. Coarctation of aorta. So aorta is the most important vessel that is present for distribution of blood in the body. So if there is a coarct inside the aorta, there is narrowing. So the blood distribution will not happen properly inside the body. That will definitely cause obstructive shock. Again, post-spinal cord or brainstem injury can result into neurogenic shock, not an obstructive shock. So obstruction basically means a sudden onset of any complication inside the body, which will affect the proper regularization and flow of the blood inside the body, like tension pneumothorax, tamponade, embolism, and coarct of the aorta. All right, next question on shock. Compensatory mechanisms in shock are. So once the body goes into a stage of shock, what will happen? How will the body try to regain back the proper perfusion? So compensatory phase basically means when the body itself makes certain changes in itself to regain the perfusion. And once it stops to make any changes, the body goes into a decompensation or decompensated shock. So once a baby goes into shock, the first stage is compensatory mechanism. So what all will happen to relieve the stage of shock? Okay, let's see the option. Will there be a decrease in the heart rate or increase in the heart rate? Okay, so whenever there's a stage of shock, the heart will always try to pump out the blood more towards all the vital organs. So it is definitely going to increase its working capacity. So decrease in heart rate is wrong. Increased stroke volume, obviously we need increased stroke volume because we need more output from the heart so that the blood can get pumped out to all the important other vital organs. There is increased vascular smooth muscle tone. So will the vascular smooth muscle tone increase? Yes, it will increase because if it is going to increase, it will cause contraction and the tone after increasing will result into proper perfusion. So if there is increased vascular smooth muscle tone, it will result into proper distribution of the blood. And also it is one of the compensatory mechanisms that happens in a early stage of shock. Now what will happen if the complete tone is lost inside the smooth muscle? So what will happen? The blood flow will not happen properly and it is also resulting into vasodilatation, that is loss of more fluid and blood inside the body. So that is why there is increased tone inside the smooth muscle. Oxygen extraction from blood. So will that happen in a stage of shock? Now it is very, very important that the vital organs like our brain, kidney, lungs, and the heart, they get properly oxygenated. So all the important blood that is present in the body, all the purified form of blood, all of that will go and get supplied towards the vital organ. Redistributing blood flow to brain, kidney, adrenals, and heart rate at the expense of skin and GI tract. Is that right? So in stage of shock, the body is actually trying to save the vital organs in the body. So definitely from the less important organs of the body like skin and GI tract, all the important fresh blood would start to get redistributed towards the vital organs, that is brain, kidney, adrenals, and the heart. So this is the compensatory mechanism that happens in a stage of shock. If the body is not able to overcome this compensatory mechanism, it will go into a stage of decompensation, that is a decompensatory shock. Okay. All right, next important question. Diagnosis of shock includes which of the following? So how can we diagnose a stage of shock? Or if the child goes into a stage of shock, what all important things can we see on clinical features, investigations, and the lab reports? Please put down your answers. Okay, is option C right or it is not right? Okay, let us see. Thrombocytopenia, definitely it will happen. Decreased platelet count is one of the most important features of sepsis, which can result into shock. Okay, so thrombocytopenia can happen. Prolonged PT and APTT, again, very, very classical feature because of onset of DIC that happens in shock. Elevated serum fibrinogen level is not seen in a case of shock. Anemia can definitely happen because of hemodilution. Neutrophilia again can happen because of sepsis. Electrolyte disturbance, very, very classical in shock because definitely the acid-base balance of the body is getting disturbed because of fluid and volume loss. So all the important features of shock include thrombocytopenia, deranged coagulation profile, anemia, neutrophilia, and even electrolyte disturbances. Is it clear to all of you? Please put a thumbs up, those who are listening to the class. Okay, let's move on to next question. Treatment of shock includes which of the following? So what are important things we need to do in the treatment of shock? So always remember the golden rule, ABC always is correct. Airway, breathing and circulation has to be maintained in all the treatment part. Apart from that, what all other important things are required for treatment of shock? Okay, so first thing, assessing of the airway is very, very important. Administering oxygen because we want a good SpO2 levels in the body. Most important thing is to establish the IV access and to treat the hypovolemia. So we need to give fluid boluses to the patient. So we have to get a good IV access. Correct the cause. Now we don't know what is the cause. It could be sepsis. It could be obstructive causes like coarct of aorta. So we need to always do the correction of the underlying cause. If the shock is refractory to fluid, then we need to give inotropic support, which can maintain the vascularity and therefore result into increased tone of the blood vessels and also improve the perfusion of the entire body and especially the vital organs of the body. So refractory shock needs to be treated by good inotropic support. Never ever wait and watch in a case of shock. It is a clinical emergency where we need to take all the important steps that is required for proper perfusion in the patient who is undergoing the stage of shock. Is it clear to all of you? So shock is a very, very important topic. All of us should know the management, clinical features, diagnosis, the clinical presentation, and what are the types of shock and the causes of shock. Okay. Let's move ahead. So another important topic, very, very simple topic, but very commonly asked in your exam is Turner syndrome. So what is the Turner syndrome? What all options are correct about Turner syndrome? Is it a chromosomal disorder? Yes, it is a chromosomal disorder, X0. Due to partial or complete loss of one or X chromosome, yes, that is also right. It happens because of partial or complete loss of one X chromosome. Is it trisomy 21 is also seen? No, that is a case that is seen in Down syndrome, not in Turner syndrome. It shows chromosomal mosaicism of 45X or 46XX and other karyotypes or multiple cell lines. It is not always that it's going to present with classical X0, but it can present with certain mosaic forms also and have the clinical features of Turner's as well. Is there formation of isochromosomes of long arm of X chromosome which can result into Turner phenotype? Definitely. So the formation of isochromosome is going to happen, which can result into affecting of the X chromosome resulting into Turner phenotype. So they can clinically present with features of Turner syndrome. So all of these are right except trisomy 21, which is a classical feature of Down syndrome. Okay, next important question. Clinical feature of Turner syndrome includes which of the following? So what are the important things that we see in a Turner syndrome? Okay, let us see one by one. They grow more slowly than their peers. So Turner syndrome definitely has got a short stature. So they will delayed puberty and lack of growth spurt. So definitely affects the puberty. So it is going to affect the puberty, and what is going to happen, that is because of the problems in one X chromosome. So they will always have delayed puberty, and the proper growth spurt that happens at the onset of puberty would be absent. They don't experience breast development. Yes, that is absolutely right, because the pubertal changes don't happen properly. So breast development is also affected. May not have menstrual cycles. So that is very, very correct. They don't have a normal genital presentation. They might not have a normal ovary. So that is why menstruation is also affected in these females. Normal ovaries, not a right option. That is affected. They have streak ovaries. So streak ovaries are classically seen in Turner syndrome. They have a broad chest. Yes, that is right. They have a widely spaced nipple and a broad chest. So that is a classical feature of Turner syndrome. They can have cubitus valgus and scoliosis. They are very well known for bony deformities. So in bony deformity, they can have complete curvature of the spine, that is scoliosis. They can have cubitus valgus, which is resulting into hand deformity. Dental problem, eye problems, these are also commonly seen in Turner syndrome. They might also have improper IQ. So they can have delayed development as well. So these are all important features of Turner syndrome. So it's very, very important syndrome, and the clinical presentation needs to be learned very well. Okay. Okay, very important question from Turner syndrome. What are the cardiovascular problems of Turner syndrome? So what all can happen as a cardiovascular problem in Turner syndrome? CVS, you should always remember the most important thing affected is aortic valve. Okay. Yes, that is option B. Overriding of aorta is that which is seen in Turner's. No, that is seen in TOF. Okay. We are talking about Turner syndrome. So in Turner, basically there is bicuspid aortic valve. Bicuspid aortic valve or coarctation of aorta, that is commonly seen in Turner syndrome. There can also be elongation of the aortic arch, which can result into hypertension. I simply remember Turner syndrome, T for Turner, and Turner syndrome tears apart the aorta. So that is how you can easily remember. Turner syndrome tears apart the aorta. Tears apart the aorta basically means it can cause bicuspid aortic valve, it can cause. So it is all going to affect the aorta, because of which they can have hypertension also. So don't get confused with other deformities of aorta. It is only basically bicuspid aortic valve, coarct or elongation. And all of these can cause hypertension. That is the only most commonly asked question about CVS part of Turner syndrome. Okay. Next important question, what is the diagnosis of Turner syndrome? How do we diagnose? Now it is a genetic disorder, so how can we diagnose Turner syndrome? All the genetic testing can be done by chromosome analysis. Yes. So any female who presents with short stature, apart from this, those who are having other important features of Turner's, we can definitely send them from chromosomal analysis. Karyotyping, we can easily see X0. So that is absolutely right. We can do cytogenetic analysis of chromosomes also, and we can also do FISH or by other PCR methods. So we basically need to see all the 23 sets of chromosome, whether they are normal or one of the X chromosome is absent. So any analysis which helps us to see the chromosome formation, that can help us to diagnose Turner syndrome. ELISA has got nothing to do with diagnosis of Turner syndrome, because that is a serum-based examination. Okay, next question from Turner. What is the management of Turner syndrome? Now, please remember that genetic diseases do not have any kind of specific management. It is always a multidisciplinary approach. Okay? Multidisciplinary approach. So because of this, basically, it's very, very important to see every complication that happens in Turner, and we need to treat accordingly. So Please answer this question. What is the management of Turner syndrome? Do we need to do height monitoring? Yes, we have to do height monitoring because they have poor growth. Cardiac evaluation, very important because they have cardiac complications due to coarctation of aorta, bicuspid aortic valve. Measurement of blood pressure, very important because they can have hypertension. We don't need to give any antidepressants or antipsychotics to them. Counseling regarding behavioral problem, again, very important. They can have mental retardation. They can have low IQ, although it is not seen in all cases of Turner's, but they could have behavioral problems also. Treatment with growth hormone is definitely done by because they have got decreased height at puberty. So they can be ideal candidates for growth hormone therapy. Ovarian hormone replacement, again, very important because they have streak ovaries. So they might not develop into normal females. So they can undergo hormone replacement therapy. Prophylactic gonadectomy, yes, that can be done. Why do we need to do gonadectomy? So that later on it does not result into gonadal cancers. So that is how we treat a case of Turner syndrome. Is it clear to all of you? Please put a thumbs up those who have understood Turner syndrome so that we can move ahead to last topic for today's discussion. All right, so let us move on to another very, very critical and very important topic, that is vitamin D. Okay. So what are the common sources of vitamin D for human beings? From where do we get vitamin D? Do we get it from cereals? Yes, we do get from cereals also. Don't just remember that sun is the only source of vitamin D. Those who don't sit inside the sunlight, still they have vitamin D. So from where are we getting our vitamin D? We get it from food products also, like cereals, cheese, fish, and milk. Green leafy vegetables is well known to give us folic acid, not vitamin D. Okay. Apart from folic acid, also iron and other important things, but definitely not vitamin D. So we get it from cereals, we get it from cheese, fish, milk, and also from sun. Okay. Now, what are the functions of vitamin D except which is not a function of vitamin D inside our body? Now, just don't remember that vitamin D is going to help in bone health. There are many, many other important functions of vitamin D. So bone health is one most common function of vitamin D. Apart from that, it also maintains a good vascular health. So good vascular health basically helps in blood pressure maintenance inside the body. Likewise, it also maintains a good cardiovascular health. Neurodevelopment is very, very important. If vitamin D is deficient, there could be neurological problems in the baby. Immunomodulation, it is very important for prevention of autoimmune diseases. So if vitamin D levels are good in the body, there is less chances of having autoimmune diseases. Prevention of autoimmune disease, definitely. So all of these are features except vision. For vision, we require vitamin A, not vitamin D. Okay. So these are all important functions of vitamin D. Okay, next important question. All are correct about vitamin D except which is the wrong statement about vitamin D? Any answers? Okay, let us see the options. Is it absorbed from duodenum? Yes, vitamin D gets absorbed from duodenum. Okay, most of the important micronutrients that we take, they get absorbed from duodenum and ileum. Okay, now it's very simple to remember. Vitamin D mein D hai and we have duodenum for D. So D is equal to D. Vitamin D gets absorbed from duodenum. After it gets absorbed, it gets incorporated into chylomicrons and transported to liver. Why? Because it is a fat-soluble vitamin. Okay, it's a fat-soluble vitamin, so it is going to get incorporated into chylomicrons and transported to liver. Subsequent hydroxylation occurs by 1-alpha hydroxylase in the kidney. So two important steps in the management of vitamin D is liver and kidney. So what basically happens here? That it gets further metabolized. So hydroxylation part happens in kidney by the help of enzyme 1-alpha hydroxylase. It is regulated by PTH, calcitonin, calcium, and phosphorus. Yes, these are all important mechanisms in the body which maintain a balance with vitamin D. It has direct relation with calcium. It is also affected by phosphorus, calcitonin, and parathormone. So if we give vitamin D supplementation, it can suppress the serum PTH levels. So if we give vitamin D from outside, it can definitely suppress the serum PTH levels inside the body. Active vitamin D has got no role in calcium hemostasis is absolutely wrong, because vitamin D and calcium, we also discussed in our last session, are best friends. So vitamin D presence in the body definitely affects calcium homeostasis. All right, is it clear to all of you? Please put a thumbs up, those who are understanding. All right. Okay, next question. Common causes of calcipenic rickets are. So as the name says, calcipenic rickets is to do with decreased calcium levels in the body. So what all could be causes of calcipenic rickets? Now see, calcium comes from outside source, that is dietary sources, and calcium is best friends with vitamin D. So whenever levels of vitamin D in the body is less, or whenever diet is not good, it can result into calcipenic rickets. So vitamin D associated disorders, anything which affects vitamin D levels can cause calcipenic rickets. Nutritional vitamin D deficiency, definitely. If the diet is not good and the child is not taking adequate amounts of vitamin D, it can cause calcipenic rickets. Congenital vitamin D deficiency. So if the absorption part is not adequate, there is some kind of congenital channel defects resulting into vitamin D deficiency. It can cause calcipenic rickets. Secondary vitamin D deficiency, again, any kind of renal problem, any kind of liver disease which is affecting vitamin D metabolism can also present with calcipenic rickets. So all those causes where calcium is low or vitamin D is low can cause calcipenic rickets. But phosphorus deficiency will not cause calcipenic rickets. It will cause phosphopenic rickets. Okay? Phosphopenic rickets. All right? So that is a very resistant form of rickets which does not happen usually. It happens in a very rare causes. So more commonly we see cases of calcipenic rickets. Okay, next question. Clinical features of rickets are. So how does a child with rickets present? Very, very important topic. What are the clinical presentations of rickets? What is the answer? So rickets basically is a disorder of bone. So whenever vitamin D is low in the body, the child can have failure to thrive, definitely. Rickets classically presents with failure to thrive because definitely the diet is not adequate, child is not gaining adequate height and adequate weight. Protruding abdomen, very, very important feature, protruded out abdomen, and also they have got protruded out skull. So these are very classical features of rickets. Rachitic rosary and harassing groove. So when we see the chest of a child, there is going to be a certain groove that is present just below the intercostal spaces. That is again because of bony deformity, and it is known as rachitic rosary or harassing groove. Pigeon breast deformity. All the bony deformities are all seen in rickets. Pigeon breast deformity is again because of decreased vitamin D levels in the body, resulting into abnormal shape of the chest. Bowing of the distal radius and ulna. So whenever we do the X-ray, we see there is a certain amount of cupping. So this cupping basically happens. Why? Because there are weak bones on the hand. So if the hand bones are weak, whenever the child will have weight bearing, the child is trying to get up with the help of their hand. So whenever they put their hands on the floor or they try to have any kind of weight bearing exercises, what will happen? The bone is going to saw like this. So there is going to be a certain amount of cupping. So there is bowing of the distal radius and ulna. Valgus and varus deformities. Again, bony deformities. There could be either abduction or adduction deformities. So valgus or varus deformities are also seen. Mental retardation does not happen in rickets. It can happen early in the stages, in pregnancy, or maybe just perinatal period when vitamin D levels are very, very low. But in a toddler or in a school-going child, if there is vitamin D deficiency, it will not have mental retardation. So rickets have got all these important features except mental retardation. Is it clear? Okay, last question for today. X-ray findings in rickets are all except. We already discussed this in the last session. So very simple. There is all findings like fraying, cupping, and splaying, but there is no radio opaque shadow. So whenever we do the X-ray of the wrist of the child, why wrist? Because obviously the changes would be seen on a weight-bearing bone. You cannot pick up any bone in the body. You have to do a weight-bearing bone. So most commonly ordered X-ray is the wrist X-ray. So whenever there is rickets, what will happen? The ends of the bone become very rough like this. This is known as fraying. Because of weight bearing, there is going to be sagging of the border. This is known as cupping. And again, because the bones are not very, very strong, so there is going to be widening of the bone. So this is known as flaying. So these are all classical features of rickets seen on the X-ray wrist. So these were all the important topics and important questions for today. So I hope all of you have understood everything. Please put a thumbs up, those who have listened to the class carefully and are happy with the session. Okay, so thank you so much. So today, I hope all of you, those who listened and those who would listen the recorded version, all of you would understand everything. If there is any doubt, we can always discuss in any of the upcoming sessions. So thank you all of you for being so patient and answering the questions very right. We are going to meet up soon with another set of important 6 to 7 topics and we'll discuss them in detail. So good luck to all of you. Thank you and good night.